I think I'm going to start to kick off. So my name is Aoife Brasden, and I'm the marketing and communications manager for Sims IVF. Just a little bit about Sims before we kick off. So Sims is part of Virtus Health Group, which is a kind of global provider of fertility treatment. So we have a great network of support from Virtus. We also have 6 locations in Ireland. So we have 3 main clinics. So 2 of our clinics are, one clinic is in Clonskeagh in South Dublin. Our other main clinic is in Swords in North Dublin. Then we have a clinic down in Cork. Then we're supported by satellite services. And so these are where you can kind of get your bloods and scans done during your treatment. So we have one in Limerick that kind of supports our Cork clinic. And we've one in Carlow that kind of supports both our Dublin clinics. And now we've actually opened a clinic in Dundalk, which is opening actually in December, which is fantastic. So we're really excited about that. So tonight obviously is a webinar on solo motherhood by choice. And we're joined tonight by Amy Murphy, who is the nursing manager for Sims IVF Swords. So if you have any questions throughout the webinar, just could you pop them into the Q&A box and we'll answer them at the end. And yeah, just the Q&A box is better than the chat function. So, okay, I'll hand it over to Amy.
Thank you, Aoife. Hi, everyone. My name is Amy. A big slide to tell you that. Thank you all for taking the time to listen to me this evening, and I hope that I can maybe put some anxieties at bay and kind of give you a little bit of reassurance and I suppose a lot of information regarding solo motherhood. Just a little bit about me. I am with the Sims group for just coming up to 8 years in January, actually, and I started off in the Clonskeagh clinic. That's where I trained, and I went on to be a senior fertility nurse and to be a theatre manager there. And now I'm actually the nursing department manager, as Aoife said, in our Swords clinic. So I've kind of progressed through. I had a kind of, when we were returned to IVF, I had about a 16-week stint there as well during the transition. So that's just a little bit about me. So what I'm going to speak to you about tonight, obviously, is ultimately solo motherhood, but just the overview of the topics I'll discuss. So first of all is the patient journey, the definition of infertility and how often that can occur, the causes of infertility, and the investigations people have to find out how fertile they are, if there's any issues, and then the treatments that you can have based on that. First of all, I'm not sure if you can see this, but this is a little flow chart of the patient journey. So I suppose the most really common question people have is how long will the process take from becoming a patient to having an IUI or an egg collection or an embryo transfer, things like that. So with regards to this, so you will fill in new patient forms online. One of our patient coordinators then will get in touch to book you in for an initial consultation. After that, then you'll speak to the doctor. Everything is, as you know, over Zoom at the moment. So you'll have a Zoom consultation or a phone call if you prefer with your doctor. The doctor would get a very, very detailed history from you, surgical, medical, gynecological, even your fertility history if you had treatment somewhere else and things like that. After that, the doctor may recommend some investigations, and you obviously will get a call from the nurse to book those investigations and go through those with you. After that, then, when you have your investigations done and completed, you'll have a return consultation with your doctor to basically go through all the test results and finalize a treatment plan. Then a nurse will schedule up your treatment. So, the doctor will take all of our treatment is individualized and it's tailored to you. So there's no one set protocol for everybody. All of your various different histories and test results will be taken into consideration and a treatment plan then created specifically for you. After that, then, when the nurse schedules up your treatment, that's when you can embark on the treatment journey. So I suppose it depends on the level of investigations required and how quick you want to move as well. It can be done really as sort of quick as 4 to maybe 8 weeks, maybe is the most realistic, from start to finish. But not everybody is ready. People need time to digest and plan and sort of, I suppose, think about their life and work and all of that. So we'll be guided by you as well on that. So infertility, the big bad word, okay? So definition, what it is no pregnancy or live birth. Apologies, I just want to pop this away. So no pregnancy or live birth after 1 year of trying if you're a female under 35, okay? We would consider then, obviously, there may be a fertility issue if you're older than 35 and you haven't conceived after 6 months. The incidence, I suppose, you'll see a lot of different statistics online and things like that, but approximately it would be about 1 in 5 people or couples would have issues with regards to conceiving, okay? Otherwise, then it's divided up. You'll probably see different, I suppose, headings online with regards to primary or secondary infertility. Okay, so primary infertility is basically the World Health Organization would say that that is when a pregnancy has never been achieved. Secondary infertility is when there has been a pregnancy, but then subsequently you have issues after that. Okay, which is more common than actually people would think, really. Another term that you'll probably hear about that we would use then is reproductive choice. So I suppose it doesn't necessarily mean there's a fertility issue, but what reproductive choice means is that when a patient is choosing to embark on treatment alone, okay, so may not have fertility issues, but may need fertility services in order to achieve a pregnancy, okay? So the causes of infertility. So look, I have condensed these down as much as possible, but it's an endless list. You know, there's lots and lots of things, but I'll go through the most common ones as well. So first of all, then, there might be an issue with egg quality or egg numbers. So quality or quantity, okay? So with that, age, naturally, egg supply, egg quality deteriorates as we get older, okay? There may be an issue then with the uterine cavity, which would mean that there could be polyps or fibroids within the uterus or the lining that could affect getting pregnant. There could be issues with maybe the endometrium, like endometriosis, or issues with the lining being receptive to a pregnancy, okay? And lastly then, there could be an issue with the tubes, the fallopian tubes, so maybe complete or partial blockages to those, okay? So this is a nice pie chart of a breakdown, I suppose, the percentages of the causes of infertility. You might be surprised to actually see that, you know, there's 30% male and 30% female. Usually fertility issues are seen as a woman's issue and, oh, it's an issue with the woman or things like that, and the kind of man falls into the background. But actually, surprisingly enough, you know, it's equal. 30% can be a male factor and 30% a female factor. So it's a common misconception out there. Then basically you've got 25% is unexplained. So it's really frustrating, actually, this, I suppose, percentage for people, because it's frustrating not only for the patient, but it's also frustrating for staff, because as humans, we love to like have a cause, treat the cause and move forward. But sometimes there's no rhyme or reason, and both investigations come back absolutely fine. Age is good, there's no issue in that sense. So it's really, really tough and frustrating, actually, the unexplained, which is actually quite high when you have a look at that graph as well. Combined means that there's both a male and female factor, which is very tough as well, because you're not only dealing with one issue, it could be two or more issues as well. And then other is kind of, it's just 5%, and that's a massive umbrella of things as well. So the biological clock. This is a term that we're all very, very familiar with and generally associated with the female body. So what this means is the pressure that the pressure you feel of needing to get pregnant in the kind of peak of your reproductive years, okay? So it's something that we are all aware of, and it happens to all women, okay? And age does matter. As I said earlier on, egg supply and egg quality does deteriorate with age, okay? Obviously, in a physiological way, it's out of our control. It's gonna happen, it's Mother Nature, it's just how the female body works. But in other ways, it is something that we can take control of if we take action sooner rather than later. So, you know, you can say, oh, look, it's just nature, it's going to happen, but we do have control over it as well, which is reassuring to know that there's options there. So, AMH. So this is something, I suppose, we would have kind of done a bit of marketing on AMH with the Fertility Awareness Week in the past, and we would have done the free AMHs for women, which was actually really successful and very helpful to a lot of women out there. So we obviously couldn't do it this time around with COVID and things like that, but hopefully we can do it again in the future because it was very, very successful. So AMH, that stands for anti-Mullerian hormone. Okay, and what that is, AMH is a protein produced by the little follicles that we have on our ovaries. It's only indicative of numbers, it's not of quality. Okay, so with regards to that, you can see a little image of the ovary on my left-hand side of the screen there. Okay, so the little circles in the ovary, that's basically their little follicles, and we have these little follicles all over our ovary. And as the month goes on, within that follicle, an egg grows and we ovulate. Okay, so we're all born with a certain numbers of eggs, and then each month we lose eggs via ovulation. Okay, so with AMH, it can be categorized into low, normal, and high, which I'll talk about in a later slide. But that's the graph essentially. There you can see the green, the orange, and the red. And on the left-hand side is the AMH value. And on the row on the bottom is your age, essentially. Okay, it's really important with AMH though not to get too fixated, because when we see, again, being human, we get fixated on numbers and values and all of that, but it's not taken in isolation. There's plenty of other factors we need to consider. Okay, so as we talked about, we need to think about the egg quality, we need to think about the uterus, the tubes, all of that as well, and the number of antral follicles present on our ovaries. Okay, so divided up into 3 categories, as I said. So the first one is normal. Yay, no, we would think that's fine, absolutely no issue at all, which is true. Thankfully, a lot of women have normal AMHs. Okay, there can be a little bit of fear around it all, but a lot of us have AMHs that are perfectly fine to achieve a successful pregnancy. Okay, now, if your AMH comes back normal and there's no other concerning factors, so if you don't know of any other issue that you have, and if you're under 35, there's no need to be concerned. Okay, if it's low, okay, so a diminished ovarian reserve, so basically that would mean it's lower than we would have expected for your age. Okay, if it is low, there could be various different causes. There could be kind of gynae history, medical history, surgical history, premature ovarian failure, and then also age, and then genes as well. So a lot of patients we would see with a diminished ovarian reserve, you know, much younger than we would expect. Generally, they would say, oh, my mother or my sister also had issues with this, and it can be, I suppose, a genetic thing as well. High AMH, okay, so you would obviously think, oh yeah, the higher the better, but that's not necessarily the case. Okay, so it can be a characteristic of something called PCOS, which is polycystic ovarian syndrome. Okay, so PCOS is not only diagnosed just on scan, you need kind of a range of blood tests as well. So all factors on scan and bloods must be present in order to diagnose PCOS. Okay, so some people have a really high reserve, but then they have normally appearing ovaries. But some people then have a normal reserve with polycystic appearing ovaries. So it's never kind of one size fits all, or, you know, there's variables in everything, I suppose. If you are concerned, obviously, that you have something called PCOS, you should get investigated. The most common symptoms are irregular or no periods, kind of excessive hair growth on your face, your chin, neck, difficulty managing weight. Okay, so it will be something if you thought you may have to get investigated for sure. So investigations. So it's divided up, I suppose there's a lot of fertility investigations. Okay, so divided up into 3 areas, one being blood tests, one being anatomical testing, and then there's another range of tests pending your history and all of that. Okay, so with regards to blood tests, so these blood tests will be requested by your doctor if the doctor deems necessary. They may request all of them, or they may request only some. So a TSH, which is the thyroid stimulating hormone produced by your thyroid gland, that we would check that, because if that's abnormal and untreated, it can have an impact on egg quality, but also it can contribute to miscarriages as well. So your doctor may ask for that to be checked. It is routine, the checking of a TSH in our clinics across the group anyway. So we like kind of TSH level below 2.5. Okay, now up to 4 would be normal outside of fertility, but it's quite a strict parameter when you're embarking on fertility treatment. Okay, prolactin we would check as well. And again, that would be pretty mandatory across all the clinics. Okay, so if your prolactin is high, that could be for various reasons, but if it is high, it can kind of impact ovulation. Okay, so if it was highly concerning, we would send you for further investigation as to why it's high. Otherwise, we can put you on medication to reduce it down. An FBC is a full blood count, and that will just check your general health, your hemoglobin, your white cells before entering into treatment, and also check your platelets with regards to clotting and surgery and all of that too. Testosterone. So testosterone is directly linked to egg quality. So if your testosterone is really low or really high, it can have an impact on the quality of eggs that you produce. Okay, so we would check that, and if you needed supplementation to boost up your testosterone, we can prescribe it. With high testosterone, there's maybe a few different treatments for that, but it's generally high in patients with the polycystic ovarian syndrome. Okay, so we would have different treatment plans for that. Rubella then is German measles. And again, this is vital to know your status before you get pregnant, your rubella status. A lot of us have been vaccinated, so we would check your immunity to German measles, because as you know, that can have a detrimental effect on an unborn baby. So that's essential that that's checked too. And then your doctor may ask for some hormone bloods. Okay, so maybe an estrogen, day 21 progesterone to ensure ovulation, and FSH is the big one. Okay, so again, as we get older, our FSH can get higher, and I suppose if you have a high FSH, that can actually indicate how well you may do in treatment with regards to getting numbers of eggs and good quality eggs and all of that. But your doctor will deem what's necessary for you. And the anatomical testing, so SIS is a saline infusion sonography. Okay, you might hear it being referred to as a high COSY or HSG. There are 2 other common names for it as well. So generally, it's a procedure that you're in and out in about half an hour. It's just done in your senses. There's no sedation involved or anything like that, and it's usually well tolerated by patients. It's kind of just a day case, not even a day case. As I said, it's 30 minutes or so. So you can kind of pop in when you're maybe some people do it on their break and stuff like that and work. So it's amazing what you can factor into your day, and nobody knows. So what this does is this will put liquid into your uterus, okay? And it will show up if there's any kind of polyps, any fibroids, anything like that that shouldn't be there or that may have an effect on treatment, okay? We will also check then the ovaries, make sure that they look normal, that there's no cysts. We'll do a little follicle count to see how many kind of antral follicles that you have there, and we'll check the tubes to see if they are open, okay? So that's what the SIS will do. I'm just going to go back a little here. So I know I had said here, so other, okay? There is a range of other fertility tests that can be done, okay? Some of the most common ones are uterine biopsies to check for an overproduction of natural killer cells in our uterus, and to check receptivity of the lining. So sometimes if killer cells are high in our body, we all have them, they're very important for fighting infection and our immune system and all of that. But sometimes they can be in overdrive and see a pregnancy as a foreign body and try to attack it, okay? So we don't want that. And then again, sometimes your lining is it's a bit it can be a little, you probably heard the term in Friends, an inhospitable uterus. That was Chandler and Monica's favorite thing. Okay, they always talked about this. So where the lining just sometimes is not receptive to an embryo. And again, there's different treatment plans that we can do to look at that as well. There's other blood tests we can look at as well, just for like high antibodies, thyroid antibodies, clotting blood tests and things like that. So there's a massive range of other tests, okay? But again, that's all based on your history. So I'll just skip here again. So basically, okay, I suppose this is what you can do. So I suppose in our clinic, we try and take control of as much as we can to take the stress off you and give you the best results, okay? But there is steps that you can take, okay? So just try and be the healthiest version of yourself before you go into treatment. So it is better if you have any bad habits, which we all do, to try and address them before you enter into treatment. I suppose it just gives you a better chance from the get-go, okay? So with regards to, it just, I suppose as well, it removes any risk in treatment, okay? And it removes any risk in pregnancy too, if you can just be the healthiest version of you. Smoking, it really just is a no. So if you smoke, you really, really should try and address that, okay? And there's plenty of supports out there. If you know, if it is something that you want to do or thinking about or trying to do for a long time, do avail of the supports out there. It really is something that you should stop before entering into treatment. Alcohol and coffee. So reduce caffeine as best as you can. We would say about kind of, if you can, keep your caffeine to about 200 milligrams a day, okay? Alcohol, like ideally none, of course, but if you are going to have alcohol, you shouldn't have more than about 3 units per week, okay? Exercise is vital, obviously, just for, you know, keeping your physical health good, really, I suppose, really positive for your mental health and all of that. So it is something that you should, if you're doing it now, that's fantastic. If you don't, maybe try and introduce a little bit, and not just, as I said, for your physical health, but treatment is tough, and we'll talk about that a little bit later on. And exercise is a great outlet for people and protected time for you, I suppose, as well. Then obviously, if you've got kind of a raised BMI, okay, so a raised, or I suppose a BMI that's under what it should be. So there's two. Again, it's like the AMH. It's low, normal, or high. Okay, so that's kind of way to look at it. So with that, we are linked with a dietitian. So if you speak to your doctor and you're struggling to gain weight or lose weight, both can have, as we know, impact on fertility and getting pregnant, and impact on when you are pregnant and all of that. But we can refer you to a dietitian, and we'll give you plenty of support around all that. I left stress to last and a question mark beside it, because I suppose there's no sort of concrete evidence to state the impact that stress has directly on fertility. Okay, we all know it's not good for us, but I suppose when you have excessive stress, you're more likely to be anxious, more likely to suffer from depression, and have raised cortisol in your body, okay? Excessive amounts of cortisol, okay? And again, that can impact fertility, okay? And just I suppose your attitude around it and all of that, okay? Just moving on then to various types of treatments. So this is particularly important for you guys if you're embarking on treatment alone. So what options are available to you? So I'll talk about them more in greater detail in just a few minutes, okay? But the first one is IUI with donor sperm, okay? The second one is IVF with donor sperm. And the third one is known donation, okay? So this is something that at the moment is only available in our Clonskeagh clinic, okay? And what known donation is that when you have maybe a friend or a sister that would be willing to basically go through stimulation, have an egg collection, and give those eggs to you, okay? And then so that would basically be another option. So again, that's available in our Clonskeagh clinic. There is a few little restrictions on that at the minute as well, but you can, if you're interested, we can talk you through that a little bit more specifically, okay? But what I'll focus on today is IUI with donor sperm and IVF with donor sperm. So IUI, what that stands for is intrauterine insemination, okay? So there's about, with an IUI, there's about a 23% overall success rate, okay? With IUI, they are a medicated cycle, okay? So you would take hormone injections for about, everyone is very different and responds very differently, but somewhere between 10 and 14 days, okay? You would take these injections. Obviously, this is a cycle in which you can use donor sperm as well. With IUI, what would happen is you would basically take the injections for 10 to 14 days, and then when the follicle gets big enough, and basically it's usually around 17 millimeters, so we keep an eye on you and your response via ultrasound throughout your treatment. And actually, probably important to say that all of our scans are done transvaginally as well, okay? So with that, we would monitor the follicle, see how big it gets. When the follicle is about 17 millimeters or more, we can be pretty confident that there is a mature egg inside. You would take a little trigger shot. After taking that trigger shot, you would ovulate within about sort of 36 hours, but we'll have done the IUI before that happens, okay? You can see in the diagram there, which is quite a good one, it's basically, we would have the sperm in a syringe, and we place a little catheter into the cervix. It's quite a similar process to a smear test, okay? And then we would push the sperm into the vagina and into the uterus, okay? With IUI, it can take a few attempts. Some people are really lucky and they get pregnant on their first go, but for some, it takes a few more attempts, okay? And naturally, it's a lot less invasive than doing IVF, and it's not as costly as IVF as well, okay? This is a great diagram of IVF and what it entails. So it kind of goes from 1 to 5, okay, going clockwise, if you can see the diagram there. So number 1 is the same starting point as an IUI. You take stimulation injections for 10 to 14 days, okay? Everybody's response is very different. Once we would deem you ready for an egg collection, you would have the eggs collected via a surgical procedure. Okay, so again, that surgical procedure is done transvaginally. Then the sperm sample would be needed at that point. So you would have your donor sperm in place and ready to go, we would have that all set at that time for you. Okay, after that, then the eggs and sperm are left in a little dish to fertilize overnight. That's point number 4. And then over the few days in between that the fertilized eggs will become embryos, and those little pink circles are, I suppose, little drawings of how an embryo would look. Okay, it's just like a multi-cell organism. Okay, and then the embryo is put back into the uterus, and again, that's kind of, I suppose, the same procedure as a smear test. Okay, so with IVF, I suppose it's more invasive than an IUI, so there is a surgical procedure, okay? It is more costly, however, you have to maximize success in the minimum amount of time, okay? As I said, with IUI, you might need a few attempts, okay? With IVF, you basically get the best chances, I suppose, that you can have in one shot, okay? Doesn't mean it's guaranteed to work the first time, but you definitely have a better chance than you would with IUI, okay? There is with IVF also a diagnostic benefit to going ahead and having an egg collection and getting the eggs checked. So the embryologist would look at it when they're collected, would look at the eggs under a microscope. So with IUI, we're assuming there's an egg there, we're assuming it's good quality. With IVF, we know there's an egg there and we know the quality, okay? With then regards to the embryo, all the embryos are monitored under a microscope, so the embryologist is able to see the development of the embryo day by day and that it's meeting the criteria of cell division and all of that. And then every patient would have an option of using something called an embryoscope, which is like a little incubator that the embryos are kept in, and it monitors cell division 24/7, okay, and basically can predict the best quality embryo and grade the embryos, and I suppose again gives you a better chance of conceiving, okay? So this, I suppose, is, I think for most patients where most of the questions come from, okay? So the donor sperm process, okay? From all of my interaction with patients over the years, I think it's the hardest thing is just to make that make the decision, make the leap to actually use donor sperm, because it's a daunting process. It's probably one of the most difficult decisions you'll make in your life, up there with buying a house. You know, it's huge, you know, so that's the hardest part. For this reason, counseling is mandatory. Okay, so you can't go through the donor sperm process without having counseling. Okay, at the counseling session, the counsellor, she's a fertility specific counsellor as well, not just general. So she's with us a very, very long time, but she'll, I suppose, explore using donor sperm and what that might bring up for you. Also, she'll go through completing the donor sperm forms and how to do that, and the donor sperm website. So it's another little additional support. Okay, and she'll also kind of give tips and guidance and advice on the prospect of telling a future child that they were conceived by donor sperm as well. So there's plenty of support there. So after you have your counselling, bullet point number 3 there, you get scheduled by a nurse who will give you a donor sperm consent form and a characteristic form. Okay. After that, then you'll go on to the Cryos website and you list your donors in your preference from 1 to 5. Okay, and we order, then you send the forms back into us and we order on your behalf. Okay, the reason we get you to order, kind of do it in 1 to 5, is because maybe your first option or sometimes second option in your donor choice isn't available. Okay, with regards to the profiles, there's 2 kind of profiles. So there's a basic profile and an extended profile. Okay, which is very, I suppose it's self-explanatory, but with the basic profile, you get kind of occupation, weight, hair color, eye color, all of that. With the extended profile, it's several pages long. You kind of get a bit more insight into the donor's personality. Some of them come with baby pictures of the donor and things like that. So it's a lot more informative. Obviously, extended profiles subsequently are then more expensive. Okay. We use the sperm bank we use is Cryos in Denmark. Okay, we've been using them for as long as I can remember, and they're very reputable and reliable. So that's why we've stuck with them. Generally, with regards to sperm, there's usually about 3 vials required for IUI and 1 for IVF. The reason being is that with IUI, as we said, it can take multiple attempts. Okay, so usually the doctor would say to try 3. Okay, and then 1 for IVF. And the reason being we just do 1 is because you would have a review after an IVF cycle to see the next steps, and we would start the process again. Okay, all donors are now identifiable. So they used to be anonymous and identifiable, but all donors now are identifiable. So at the age of 18, the child would have a right to access identifying information about that donor. Okay, you as the mother can't, but the child can. Okay, and obviously the donor has no legal obligation to the child or anything like that. The next thing is something called an SI 545 consent. So this is actually a government consent. It's not a SIMS IVF consent. It's something that the government brought in, it was introduced in May 2020 actually, and it needs to be completed for any treatment that's using a donor gamete, and a donor gamete meaning donor sperm or donor egg. And it's particularly important with regards to birth registration, and if you're in a same-sex relationship or anything, that the partner goes on the birth cert and all of that. So it's a protection for you as well. Okay, but it's good to know about these things in advance as well. So egg freezing. So I said I'd speak briefly on egg freezing, and I know obviously the outcome of egg freezing is not directly related to a pregnancy, but it is the beginning of motherhood for some women, and then a way for women to take control of their fertility as well. Okay, so it is fertility preservation. So younger eggs can be used later on. So as we know, we're all very career focused and all of that. There might be other interests, other things, other commitments, family commitments that we have to prioritize over this and getting pregnant and all of that. But with regards to egg freezing, I suppose it's like a little insurance policy. So you basically would have your eggs frozen, keep them there and use them at a later date. So you'll have young eggs being, I suppose, used in an older person's body. Okay. And then I say here mainly for younger women. Okay. And I suppose this is due to the fact, I suppose what I was speaking about earlier, that age AMH and egg reserve and egg quality does diminish as we get older. So you kind of want to freeze your eggs at the optimum time, the peak of your reproductive years. Okay, it is better. Doesn't a lot of women come through later on? It's just you might not get the same response, and you might need to do multiple cycles. What we want is that you do a cycle and get the max number of eggs to reduce the number of cycles that you need to do. Okay, because with eggs we have to thaw them. Okay, and the thawing process, I suppose the freezing and thawing process over the years has been perfected immensely, and it's really, really fabulous. Okay, however, naturally there is a drop off in numbers when we thaw eggs, so you want the biggest pool you possibly can have starting off. Okay, and if you do want to use your eggs going forward, say if you meet someone or anything like that, you can fertilize the eggs, so you can do that with a partner, or you can come back and do donor sperm as well. So costs of treatment, and I don't just mean obviously money. Okay, it's divided up, I suppose we have it there into 4 sections. There's a financial cost, physical cost, an emotional cost, and a psychological cost. Okay, so obviously I will discuss all these with you in detail as well. We know IVF is not cheap. Okay, so it's self-explanatory. Everybody knows IVF, IUI, fertility treatment is very, very costly, and unfortunately there is no grants or subsidies or anything like that with regards to governmental support and stuff like that. Okay, I'll break it up into physical. Okay, injections, nobody likes them, no one at all. Okay, that's just something that, again, we've had patients come through with needle phobias, and by the end of it have been absolutely cured and have spent years trying to get better and all of that, and gone to hypnotists and CBT. But actually, if you want to battle a fear of injections, IVF or IUI will do that for you. Like any pregnancy or an embarking on on pregnancy and conceiving, there's risk of miscarriages and ectopics and the associated pain and bleeding and trauma with those. There's a risk of twins or multiple births. Okay, now look, with twins and multiple births, there is definitely a risk with regards to the mother and to the babies if you do have multiple births. Okay, so we would always recommend single embryo transfer. Okay, it is gold standard practice. It's the safest option for you and a baby as well. Okay, there are some cases where doctors will agree to put more than one embryo back. However, that would be, you would need to be counseled of the risks and I suppose your whole history taken into consideration and your age and all of that. But gold standard practice is to transfer one embryo back. And if we're talking about IUI, we would generally not proceed when there's more than 2 follicles. But again, this can be another discussion if there's 3, but that's a bit more specific, and that can be discussed if that is something that happens in your cycle. Hyperstimulation, so it's probably something that people are aware of. People always talk about even when patients have never done treatment before. So patients will ask me, oh, is there any sign of hyperstimulation? So people are educated around that as well. What hyperstimulation is OHSS, which is ovarian hyperstimulation syndrome. It generally happens only with patients that have polycystic ovarian syndrome. So they have lots of follicles that are at risk of growing during the cycle of injections. Okay, what happens is when the eggs are collected, fluid builds up in the pelvic cavity and can cause you to become unwell. Okay, but we manage that really closely, so it's something we are always trying to prevent. So thankfully we don't have a high incidence of it. Okay, and then with regards to egg collection, obviously it is a surgery, so there's a risk, like usual surgical risks, so bleeding and infection. They're the 2 main ones, and risks with sedation, I suppose, the risks you'd hear in a general hospital around sedation. Okay, so emotional and psychological. Okay, so I suppose, as it says there, it's the hardest and highest cost. Okay, so again, with all my interactions and care of patients over the years, in the good and the bad scenarios, patients would always say to me that they will go through all the injections in the world, but it's the waiting, it's the unexpected And every phase is like a milestone. So you have to grow follicles, you have to get eggs, the eggs have to fertilize, you have to get embryos, you have to get pregnant, you have to get to your pregnancy scan, and for that to be okay, there's a constant milestone. And there's always a celebration at every milestone, which is really lovely. But then it sort of leads into, okay, the next step, what do I have to worry about now? What's my next phase? So I always find that I suppose, it kind of, the empathy grows and grows and grows as you see those cycles going on for patients, because I think it is the thing that patients struggle with most. They'll have all the scans and the injections and procedures and invasive procedures, but it's that stuff that's, the toughest. So like family and friend support is just non-negotiable. You do need to have that throughout your treatment cycle, or any support person. It doesn't matter who they are, but somebody that's your go-to. I know people are private and do like to keep fertility treatment, within their little bubble, and that's absolutely fine. But even if you just have one person that you could just talk to about what you're going through is enough. You don't need to tell a lot of people. Okay. And then self-care is really important. And we've heard so much more about that during the pandemic. I think we all thought we knew what self-care was, and we actually really didn't, So self-care, as you know, looking after yourself nutritionally, exercise, hobbies, mindfulness, all of that, it's really, really important, okay, to just have a good balance. Because meditation is great as well, because sometimes treatment, and I've seen it so many times, can just consume patients. It really, really can. And I get it, it's a massive investment. I totally get it, and I understand how you can just fixate on that. But it is really important to carve out some time where you don't think about injections, you don't think about eggs, you don't think about procedures. And even if it's just an hour a day where you're just not in the fertility zone, okay, I would really recommend that. Put up your bubble, prioritize you. And when you do that, you'll just know that no matter what the outcome, you've given it your all. So top tips, picture of a very inspirational lady down there. So look, there's four areas there. Look, and there's probably about 1,000 top tips, okay, but I've sort of condensed them into 4. So look, be determined, don't lose hope. You've got this, okay? Always know you have got this, no matter what comes your way, okay? We are strong human beings, we are resilient. And I think I remember hearing a lovely quote from Frida Kahlo, and it's one of her most, I suppose, poignant quotes, is that we can endure much more than we think we can. Okay, so do remember that we are resilient and we can do this. Okay, be flexible. Okay, I know it's very hard with work life and family life and all of that, but treatment is unpredictable and does require a certain level of commitment from you as well. Be flexible and be open-minded, because again, at various different stages there can be little speed bumps, and we'll get you through them, but it doesn't always go to plan. Okay, so keep that open mind. It's really important. And I do find patients that have that open mind are happier for it, actually, and much less stressed. And then again, emotional resilience. Okay, I spoke about that already. We can endure much more than we think we can. Okay, so self-care is the key to emotional resilience. Talk, cry, scream, laugh, whatever you need to do throughout your treatment. Okay, all those emotions might even occur within a half an hour. Okay, I only looked after a patient that was, I think in 5 minutes, she was laughing and crying and all the things all at once for various different reasons, and it's important to know that's normal. And I think when people feel validated like that, they just feel more reassured and secure in the whole process. Just go with it. Whatever you're feeling, go with it at the time, and just do whatever you need to do to get yourself through it. Okay, I hope that was really helpful. I'm aware I'm talking for 45 minutes now.